Transient ischemic attack. Clinical picture of TIA. Neurologic deficits are completely and spontaneously reversible in less than 24 hours. No signs on CT. TIA is usually characterized by focal neurological symptoms. There are two main groups of TIA symptoms. General, usually manifest as headache, dizziness, short loss of consciousness. Focal symptoms depend on the vessel territory. TIA's in carotid distribution. Subjective sensory disorders. Motor disorders. Transient aphasia. Blindness or reduction of vision. Focal Jackson motor or sensory epileptic attacks. TIA's in vertebrobacillar distribution. 70% of all TIAs. Vestibular syndrome. Brainstem, cerebellum syndrome. Paresis of oculomotor muscles. Bulbar syndrome. Alternate syndromes. Cortical vision disorders. Atonic, adynamic syndrome, drop, attacks. Paroxysmal hypersomnic and catalepsic syndromes. Temporal epilepsy. Diagnostic tests in stroke. Diagnosis critical pathway. Initial ACG, cardiac enzymes. Hemogram, blood cell count. Coagulation tests, NIR. For etiologic diagnosis, genetic conditions, test for C protein, S protein, factor V, factor VIII, fibrinogen, etc. Blood proteins, electrophoresis. Glucose, renal function studies, plus/drug screen. Diagnostic tests non-contrast CT of head. Differentiate hemorrhage versus ischemia. Most ischemic strokes are negative by CT for at least 6 hours. Hyperdensity indicating infarct seen 24 to 48 hours. Can identify hemorrhage greater than 1 cm, and 95% of SAR. If CT is negative, but still considering SAR may do lumbar puncture. Diagnostic tests depending on circumstances. Other helpful tests. Echocardiogram identifies mural thrombus, tumor, valvular vegetations in suspected cardioembolic stroke. Transesophageal echocardiography to see atria. Echography of arteries in the neck, Doppler, duplex. Finds out the absence or presence of stenosis and occlusions of magistral arteries of head and neck. Dissection. Degree of obstruction of the blood vessel. Type of plaques, risk of emboli formation, diagnostic tests. Angiography, gold standard, identifies occlusion or stenosis of large and small vessels of head/neck, dissections and aneurysms. Useful especially in hemorrhage before surgical intervention. Angio-CT, MRI scan, identifies large vessel occlusions, may replace angiography in the future. MRI scan identifies posterior circulation strokes better and ischemic strokes earlier than CT. Emergent MRI considered for suspected brainstem lesion or dural sinus thrombosis. MRI techniques for recent ischemic stroke, diffusion and perfusion techniques allow rapid confirmation in view of thrombolysis. Treatment of ischemic stroke. Ischemic stroke management. General management. General support measures. 4. Oxygen, monitor, elevate head of bed slightly. Treat dehydration and hypotension. Avoid overhydration, cerebral edema. Avoid IVF with glucose, except if hypoglycemic. Fever, worsens neurologic deficits. Hypertension. Treatment indicated for SBP greater than 220 mm Hg or mean arterial pressure greater than 130 mm Hg. Lowering BP too much reduces perfusion to penumbra, converting reversible injury to infarction. Use easily titratable RX, labetalol or enalaprilat. SLCA channel blockers should be avoided. Ischemic stroke treatment, other management issues. Surgical. Decompression, in selected cases. Removal of clot, stenting, IV administration of thrombolytics. Brain edema prevention/treatment, mannitol, lupdynex, furosemide. Ischemic stroke, treatment. Etiologic. thrombolysis. Tissue plasminogen activator. 3 hours from the start of stroke. IV, generally or directly in the obstructed artery. Heparin, prevents extension of clots/formation of new clots. Drugs that dissolve the fibrin clots, called thrombolytics or fibrinolytics, are the indicated acute therapy for stroke. When given intravenously within 3 hours of the start of stroke symptoms, recombinant tissue plasminogen activator, TPA, is clearly effective as it reduces progression of the ischemic lesion and thus improves the functional outcome. Thrombolytic therapy with TPA should not be initiated more than 3 hours after onset of symptoms of stroke because effectiveness diminishes after that time. Thrombolytic therapy is associated with a significant risk of bleeding, particularly after more than 3 hours after onset of ischemic stroke, when conversion to hemorrhagic infarction, that is bleeding into an infarct, is feared. Thrombolysis background. NIH/9 study. 624 patients, trial with IV versus placebo. Treatment within 3 hours of onset. At 3 months, patients treated with PA were at least 30% more likely to have minimal/no disability, absolute favorable outcome in 11 to 13%. 6.4% of patients treated with PA developed symptomatic ICH compared with 0.6% in placebo group. Mortality rate at 3 months not significantly different. PA group had significantly less disability. FDA approved in 1996. PA dose and complications. Fort PA total dose 0.9 mg/kg, max 90 mg. 10% as bolus, remaining infusion over 60 minutes. Blood pressure and neurological checks every 15 minutes for 2 hours initially. Treatment must begin within 4,5 hours of symptoms and meet inclusion and exclusion criteria. No ASA or heparin given next 24 hours after thrombolysis. Thrombolysis criteria in ischemic stroke. Inclusion criteria. Age 18 years or older. Time since onset well established to be less than 3 hours. Clinical diagnosis of ischemic stroke. Exclusion criteria. Minor/rapidly improving neurologic signs. Evidence of intracranial hemorrhage on pre-treatment non-contrast head CT. History of intracranial hemorrhage. High suspicion of SAR despite normal CT. GI or GU bleeding within last 21 days. Criteria for thrombolysis. Other exclusion criteria. Known bleeding diathesis. Platelet count less than 100,000/3. Heparin within 48 hours and has an elevated PTT. Current use of anticoagulation or PT greater than 15 seconds or INR greater than 1.7. Intracranial surgery, serious head trauma or previous stroke within 3 months. Major surgery within 14 days. Recent arterial puncture at non-compressible site. Lumbar puncture within 7 days. Seizure at onset of stroke. History of ICH, AVM or aneurysm. Recent ME. Sustained pre-treatment systolic pressure greater than 185 mm of mercury or diastolic pressure greater than 110 mm of mercury despite aggressive treatment to reduce BP within these limits. Blood glucose less than 50 or greater than 400 mg/dl. Anticoagulants heparin, unproven. Patients may expect fewer strokes but benefit is offset by increased ICH. Similar results with low molecular weight heparin. Use of heparins or heparinoids for a specific stroke subtype or TIA cannot be recommended based on available evidence. Prevention of decubitus complications. Drug therapy in ischemic stroke. Majority of the patients are not thrombolysis candidates. Secondary prevention. Stroke secondary prevention. Prevention of risk factors, correct treatment of diabetes, arterial hypertension, dyslipidemia, giving up smoking. Antiplatelet agents. ASA, risk 20 to 25% versus placebo. 50 to 300 mg dose and will not interfere with the therapy. Dipyridamole, alone, 200 mg bid, risk 15%. Dipyridamole plus ASA, astaxanthin, agrenox. Clopidogrel, 75 mg QD, 0.5% absolute annual risk reduction when compared to ASA. Triflutalum, Aflin. Good for peeps who cannot tolerate or fail ASA. Stroke secondary prevention. Anticoagulation, vitamin K antagonists. Warfarin, acenicamaril. First line in secondary prevention in patients with atrial fibrillation or other cardiac embolism conditions. Less than 75 years, embolic risk, atrial fibrillation. Greater than 75 years, individual evaluation of risk/benefit. 2 Indian rupees and 50 paise, 2-3, lifelong or whole duration of AF, Vidal, Martindale. Drug therapy in ischemic stroke. Cerebral vasodilators. Vinsamine, vinpocetine, nisergoline, bentoxifylline. Ginkgo biloba. Cerebral trophic agents. Piracetam, primiracetam. Cerebrolacin, actovegin. Neuroprotective therapy. Prevention of stroke in atrial fibrillation. Neuroprotective therapy. Neuroprotective therapy is designed to save the penumbra, or the area surrounding the core of the primary ischemia, from the damage caused by reduced blood flow to this region. Neuroprotection targets. Growth factors. Calcium channels. Glutamate receptors. Free radicals. Nitric oxide. Proteases. Cell membrane components. Apoptotic pathway molecules, for example BCL2 promoters. Neuroprotective drugs, cerebrolacin, calcium blockers. Neuroprotective therapies are currently under development to save the penumbra, the area surrounding the core of the primary ischemia, from the damage caused by reduced blood flow to this region. September 2007. 23. Hemorrhagic stroke. Hemorrhagic rupture of a vessel. Prevention of stroke in atrial fibrillation. Stroke. Hemorrhagic rupture of a vessel. Rupture produces injury by distorting, compressing and tearing the surrounding brain tissue or by increasing intracranial pressure. There are two different types of stroke. One is called ischemic stroke, and is caused by insufficient blood flow into part of the brain. The other is called hemorrhagic stroke and is the result of rupture of a blood vessel. During a hemorrhagic stroke, arterial rupture causes bleeding within the brain and its ventricles, which produces injury by distorting, compressing and tearing the surrounding brain tissue or by increasing intracranial pressure. September 2007. 25. Intracranial hemorrhage. Prevention of stroke in atrial fibrillation. Intracranial hemorrhage. Circle of Willis. Anterior cerebral artery, ACA. Middle cerebral artery, MCA. Basilar artery. Bleeding into the subarachnoid space from a ruptured aneurysm or other vascular malformation produces a chemical, sterile, meningitis and can induce vasospasm, particularly in the vessels constituting of the circle of Willis. If the vasospasm is sufficiently severe, it can result in cerebral infarction and death. Intraparenchymal hemorrhage may be relatively benign. Bleeding into the region of previous infarction causes no additional functional loss. Primary parenchymatous hemorrhage damages tissue in several ways. However, if a large vessel ruptures, the amount of bleeding into the brain can be severe. The portion of the vascular distribution distal to the site of rupture is no longer supplied with blood, resulting in infarction. At the site of rupture, bleeding into the brain may cause traumatic injury to the exposed brain tissue, and blood or its breakdown products in the parenchyma damages brain tissues. Also, the extravascular blood in the brain parenchyma increases total brain volume, and the edema that rapidly forms in and around the site of bleeding increases the intracranial contents. Because the cranial capacity is fixed, intracranial pressure rapidly increases and cerebral herniation may occur. Blood in subarachnoid space. Vertebral arteries. Posterior cerebral artery. Intraparenchymal hemorrhage may be relatively benign. Bleeding into the region of previous infarction causes no additional functional loss. At the site of rupture, bleeding into the brain may cause traumatic injury to the exposed tissue, and blood or its breakdown products in the parenchyma damages brain tissues. September 2007. 26. Cerebral hemorrhage, etiology. Arterial hypertension. Segmental arteriolosclerosis, fibrinoid necrosis, hyalinosis, sclerosis of the media, lipohyalinosis. Small diameter arteries, 0,08 to 0.3 mm. Microaneurysms, arteries with 0,3 to 1 mm diameter. Damages the intraparenchymal arteries. Penetrating arteries, near their origin in large arterial trunks. MCA, bacillary trunk, superior cerebellar artery, antero-inferior cerebellar artery. More frequent location of hemorrhage within the basal ganglia, internal capsula, thalamus, pons, cerebellum. Microaneurysms. Impenetrating arteries. Cerebral hemorrhage, etiology. Vascular malformations. Arterial aneurysms. Arteriovenous malformations. Other small blood vessel malformations, cavernoma, telangiectasia. Mycotic aneurysms. Amyloid angiopathy. Amyloid deposits in the arterial walls. All types of intracranial bleeding. Tendency to recidivate. Coagulation abnormalities. Genetic, leucemia. Anticoagulant treatment. Drug/alcohol abuse, tumors, systemic diseases, pregnancy, cerebral venous obstruction, topographical forms basal ganglia lobes. Localized, intracerebral hematoma, topographical forms brainstem, cerebellar primary, pontine. Secondary, mesencephalon, in rapid rising of the intracranial pressure in tumors, hemorrhage above the tentorium. Cerebellar. May lead to severe respiratory problems, coma, decerebration. Decompression may be urgently needed. Brain hemorrhage, treatment. Prevention. Correct treatment of arterial hypertension. Vessel malformation surgical treatment. Correct monitoring of anticoagulant treatment. Non-surgical. General measures of support. Treatment of seizures, other complications. Treatment of brain edema, lupdynics, mannitol. Surgical. Bleeding control. Removal of hematoma. In lobe hemorrhages, cerebellar hematoma. Rehabilitation. Subarachnoid hemorrhage. Causes of SAR rupture of an existing aneurysm. 85% anteriorly, especially the anterior communicating artery. Aneurysmal size often greater than 7 mm and less than 10 mm. Rupture of an avenue malformation. Trauma. Tumor. Distribution of congenital cerebral aneurysms. Arterial aneurysms. Vascular malformations. Subarachnoid hemorrhage. Bleed into the subarachnoid space in the brain. Subarachnoid hemorrhage. Clinical picture. Sudden onset. Intense headache. Vomiting. Meningeal syndrome, but no fever. Consciousness alterations. Usually no other focal signs. Diagnosis. History. Non-contrast CT. May need LP. If CT is negative or equivocal. If CT unavailable. Subarachnoid hemorrhage. Initial management. ABC. Bed rest. SBP less than 160 mm Hg. Treat any pain/anxiety. Hydralazine/SNP/others. May also increase risk of infarction. Prevention of seizure. Load with phenytoin. Monitor closely for signs of raised ICP. Intubated, if not already. Hyperventilated. Mannitol. Surgery, clips/coils/drains. Complications. Early. Rebleeding. Arterial spasm. Acute hydrocephalus. Late. Recurrence. Psychiatric sequelae. Chronic hydrocephalus. Vasospasm occurs 3 to 30 days after the initial bleeding. Peaks at 4 to 12 days, worst time for surgery. Associated with increased mortality in the first 2 weeks post-bleed. Occurs in 70% of patients presenting with SAR. Diagnosis: angiogram or MRA. Doppler, increased velocity of blood. Prevention: hypovolemic hypertensive hemodilution. Nimodipine. Vasospasm. Venous system. Cerebral venous system. Superficial system. Drains into the venous sinuses. Central system. Drain in a large, short venous trunk, the great vein of Galen. Basal system. Drains the blood into the basilar vein and then to the great vein of Galen. Jugular veins. Cerebral venous thrombosis. Causes: infectious, significantly decreased since antibiotics. Local: general. Non-infectious: local, trauma, surgical interventions, tumors, arterial thrombosis, malformations. General, surgical, pregnancy, postpartum/post-abortum, drugs, dehydration, advanced liver or kidney disease. Idiopathic cerebral venous thrombosis. Venous sinus thrombosis. Increased pressure in the preceding veins, depending on the anastomosis system. Increased intracranial pressure. Superior longitudinal sinus, role in resorption of the CSF. Cerebral veins thrombosis. Secondary hemorrhage is more frequent. Cerebral edema, venous infarcts. Seizures, cerebral venous thrombosis. Clinical picture: increased intracranial pressure, headache, nausea, papillary edema, consciousness abnormalities. Focal or generalized seizures. Meningeal syndrome. Focal signs: septic CVT, fever, other signs of severe infection. Cerebral venous thrombosis. Cavernous sinus thrombosis. Staphylococcus infections of the face, orbitary, sinuses, teeth. Other ENT infections. Trauma. Usually the clinical picture is marked by the septic syndrome. Venous stasis. Palpebral edema, chemosis, exophthalmia. VITH and then third, 4th, and ophthalmic ramus of the fifth nerves palsies. Often clinical signs are bilateral, the two sinuses are connected.